good evening to all the aspirants and Dr. Varun Pushkarna too. Well, today topic is cardiology, and the speaker we have here is Dr. Varun Pushkarna, who is the senior consultant in internal medicine at Fortis Escortis Hospital, Amritsar. Over to you, sir. Thank you.
Thank you. So, without wasting much time, let's begin with the class for today. So, cardiology in MRCP is basically I would say it is one of the most uh, encompassing branch. So, when you read about cardiology, you read about some neurology, you read about some cardiac surgery, you read about vascular diseases, and of course, the cardiac pharmacology is huge. So, we'll first begin with the broader case based topics that come to the exam, and then in probably in the next class, we will take individual diseases also. But I just want to bring you to the frame of examination where the questions are framed according to the presentation of the patient. So, we will first discuss the presentation types, a synopsis, and then we will probably go into each diseases. It is not easy to cover cardiology whole of it in 2 to 3 classes, but let's see if I can do justice to it. So we'll begin with the most important cardiology topic. People read about um, hypertension, cardiomyopathies, acute coronary syndromes, heart failure, but then people don't read about syncope. That is one of the cornerstones of question that come to the exam. When you generally read syncope, you read about the neurological syncope. So many times it is missed from the cardiological perspective. So let's see. We all know that syncope is defined as a transient loss of consciousness due to global cerebral hypoperfusion. So this is the definition. That is, it's a transient loss of consciousness due to cerebral hypoperfusion. It could be reflex syncope like vasovagal, situational, carotid sinus, hypersensitivity, um, micturition syncope is also reflex kind of syncope. Orthostatic is dehydration, medication induced like patients on antihypertensives, patients on beta blockers, patients on digoxin. They can have orthostatic hypotension because and diuretics, of course. So so many drugs are there which can cause autonomic failure. For example, diabetes. For example, autoimmune diseases, so on and so forth. So these are the basic conditions where orthostatic hypotension is seen. As far as cardiac is concerned, it is mainly due to number one, arrhythmias. Which arrhythmias? See, syncope will happen in a normal structural heart with ventricular tachycardia and ventricular fibrillations. Although atrial fibrillation, atrial flutter, they can also cause syncope only if there is a poor LV function. That means there is LV dysfunction. Then it can also cause syncope. Then comes the bradycardia part, that is complete heart block, second degree Wenckebach, Stoke-Adams attacks, so on and so forth. Structural heart diseases like hypertrophic obstructive cardiomyopathy. So it can cause syncope. Aortic stenosis, that is a valvular heart disease which can cause uh, syncope. So there are, whenever cardiac comes to the mind, people usually say arrhythmia, and then the list is complete for them. But then I keep asking my students to enumerate more cardiac causes of syncope, and then they just black out. They have syncopes. So it is not only arrhythmia which causes syncope, but structural heart disease like HOCM. Patients present with sudden cardiac arrest. So sudden cardiac arrest is a variant of syncope only where the consciousness never returned. Syncope is where we know that it was just a transient loss of consciousness. Then is aortic stenosis. And then history clues are important where we need to understand trigger factors, whether the prodrome was present or any associated symptoms are there. We can do an ECG, a tilt table test, echocardiography, and of course, ambulatory monitoring of ECG, that is 24-hour Holter monitoring. Why do you want 24-hour Holter monitoring and Any other ambulatory monitoring that we require in a patient who is being evaluated for syncope? Anyone? So there are two ambulatory monitorings that are required. One is 24-hour Holter. Anything else? Come on, guys. You are preparing for MRCP exam.
Ambulatory BP monitoring.
Yes, ambulatory BP monitoring, ABPM. So, why ambulatory BP monitoring? Because orthostatic hypotension will start reflecting in that ambulatory BP monitoring. So, whenever a patient comes to you with syncope, after the initial assessment, what you do is you'll just look at the age group. If it is a young adult or an adolescent with no comorbidities or risk factors, compatible symptoms, and alternatives are unlikely, then you should consider neurally mediated, usually in females. And there are more chances that these patients can have, a supraventricular arrhythmia. So you can try a carotid sinus massage. And in case the carotid sinus massage will again cause a syncope, then the patient has a disease known as carotid sinus sensitivity. But if carotid sinus massage does not cause syncope, then it is vasovagus reflex vasodependence. Then comes the other factors where you do an ECG, and if the ECG is normal, we call it orthostatic uh, assessment is important. So we do orthostatic. If the orthostatic changes are present, we do a hemogram to see if there is anemia, because sometimes GI blood losses, patients present with syncope every time they have a GI blood loss. Like every time they pass melena, they have syncope before that. So the history is like I had a syncope, then I woke up, and the moment I woke up, I was having blood in my stools. Then, of course, if hemogram is normal, then we call it orthostatic hypotension due to dehydration, volume loss, and drug induced. In a normal ECG with absent orthostatic changes, we can focus on neurally mediated, low venous return, outflow obstruction, focal neurological symptoms, and metabolic patterns of presentation. In metabolic, we need to rule out blood glucose, low blood glucose, that is hypoglycemia, and yes, adrenal insufficiency, which is known as Addison's disease, can manifest as a metabolic source of syncope. Because of, in Addison's disease, what do we have? We have hyponatremia, we have hypoglycemia, we have hypotension. It is only potassium which is high. Other than that, everything else is hypotension. Then the hypothermia. So these patients who have Addisonian crisis or Addison's disease can also present with syncope. Then people who have no orthostatic changes, but they presented with syncope-like features, and focal neurological symptoms, may be weakness of a limb or maybe jerky movements. We do a CT head, and in case there is any specific finding, we can identify stroke, TIA, SAH, and complex migraines in CT head. Otherwise, what we'll do is we'll get an EEG done. And in case we get an EEG done and we find that there is a seizure activity, then this syncope becomes seizure. Then we define it as epilepsy. Okay. Now, whenever there is an outflow obstruction suddenly, like in HOCM, like in pulmonary artery occlusion, we definitely patient will have a syncope. So outflow obstruction from the pulmonary end, we'll like to do a pulmonary CTA and an echocardiography. In pulmonary CT angiogram, we'll find out about pulmonary embolism. And in echocardiography, we can find out dissection of aorta, valvular stenosis like aortic stenosis, or HCM. So these are all potential cardiac causes which can cause syncope. Of course, in case of venous return, we would like to see if there is any beta HCG levels are increased, for example, in pregnancy, or in echocardiography ultrasound, if we can find out that there is a pericardial tamponade. In pericardial tamponade, syncope is a very, very common presentation. Patient, right now I have two patients in my cardiac unit who presented with syncope but evaluated to have a massive pericardial tamponade. The reasons were, one was uremic, the other was having breast malignancy. So pregnancy and tamponade. Now, in cases where ECG is directly abnormal, we can consider dysarrhythmia. and we need 24-hour ECG or maybe a loop recorder for 7 days, and we can identify arrhythmia and then start antiarrhythmics. Again, an abnormal ECG does not necessarily mean that the patient has arrhythmia. It may have ischemia, it may have a complete heart block, and we need to see because ischemia can lead to sudden ventricular tachycardias, which may not be reflected in immediate ECG. So, for that, of course, you will need continuous monitoring and troponin levels, and then you will reach to a conclusion. Is this algorithm helpful to you for identifying syncope? Yes.
Yes,
So
sir.
basically, immediately you should find out if there are any reversible causes and you should get an ECG. In case ECG is normal, think about other causes like metabolic, like orthostatic, like something in the brain, neurological syncope, something in the heart, structural heart disease, or something outside the heart like tamponade. And of course, if ECG has some changes, these changes can be arrhythmia related or they can be ischemia related. If it is an ischemia related, then you should rule out by the process of, that algorithm, that get a echocardiogram baseline. If still not convinced, then get a stress echo, or then you can take up for CT angiogram or a coronary angiogram. Okay. So once we are done with the basic work, let's see some questions. A 72-year-old man collapses while shaving. This question, I don't know how many times it has appeared in MRCP exam. A 72-year-old man collapses while shaving. He reports no prodrome but feels lightheaded after turning his neck. Physical exam reveals a regular pulse of 70. ECG is normal. What is the most likely diagnosis?
Carotid sinus hypersensitivity.
Perfect. So let's go back to the let's go back to this algorithm. So we found out that our patient has carotid sinus sensitivity. So in case you want to diagnose this patient, what will you perform? Which test will you perform in the OPD? You will do have everything ready. So a carotid sinus massage. In case you do a carotid sinus massage, we will find out syncope that is triggered by neck movement or carotid pressure is characteristic. So diagnosis is confirmed. So it is the question you can get is how to confirm. Confirmation is by carotid sinus massage showing asystole or significant bradycardia. So you should do it in a setup where you have everything like defibrillator, adrenaline, atropine, intubation, immediate transvenous pacing. So everything you should be having. Students, I have to go for like 5 minutes, 10 minutes. I'll be back. I'm going to the hospital. It is just next to my home. I'll be back. I told you there is a patient who's sick. I'll be back in like 10-15 minutes. Okay. All right. So continuing with the question. A 25-year-old woman collapses after standing in a crowded room for an extended period. She's just 25. So she reports feeling dizzy, nauseous, and sweaty before losing consciousness. She regains consciousness rapidly without any residual confusion. What is the most likely cause? Post tachycardia syndrome, reflex syncope, cardiac arrhythmia, or seizure?
Reflex syncope.
Reflex syncope. Very good. So why do you say that reflex syncope?
Probably it is vasovagal attack in crowded.
Yeah, so reflex syncope is vasovagal. Unless proven otherwise, it is the most common cause of syncope in young individuals associated by prolonged standing, heat, excessive sweating, or stress. So there is a prodrome always, just like a seizure or migraine, there is a prodrome. Dizziness, nausea, feeling of pins and needle sensations throughout the body. And there is rapid recovery which supports this diagnosis. All right, good. Okay. A 35-year-old man with history of myocardial infarction presents with a syncopal episode. He has no warning and immediately regains consciousness. ECG shows a prolonged QT interval. What is the next step in the management? Reassure, Holter monitoring, tilt table testing, or ICD? So what is the diagnosis and what is the treatment?
So prolonged QT.
So prolonged QT happens in cases of So either it can be congenital or it can be acquired. Congenital is long QT syndromes, some potassium channel syndromes, and then acquired is whenever there are either ischemic heart disease because it is a problem with the repolarization, or there are certain drugs which are being given like
Yes, ondansetron and this
okay.
sotalol.
Yeah, so name few drugs which are given in ischemic heart disease or maybe heart disease, like amiodarone, like
Yes,
mexilatin, like
yes.
xylocard. So these, I mean, lignocaine. These are the drugs that prolong sodium channel blockers. All of them prolong the QT interval.
Yes.
So we need a ICD for this patient because syncope with structural heart disease that is post MI and a prolonged QT interval will lead to R on T phenomena, R on T phenomena, and leading to ventricular arrhythmia. Which kind of ventricular arrhythmia is very common in patients of long QT syndrome? Anyone? Anyone?
Torsades.
Yes. So it is TDP, torsades des pointes. So what is the treatment? Immediate treatment is
Magnesium.
injection magnesium sulfate. And what is the long-term treatment?
Amiodarone.
See, already QT is prolonged. Amiodarone will further prolong it.
So ICD.
Yes. So the answer will be ICD. So you have a witnessed syncope. One episode of syncope in, in first year after. Okay, I'll tell you something else. So what are the indications of ICD in a patient post-infarction? Post-MI indications of ICD. Anyone? One is, you should remember that the cutoff time is 45 days. For what? So if after myocardial infarction and after PCI, the ejection fraction of the patient remains less than 35% for more than 45 days, despite ACE inhibitors, despite ARBs, despite ARNI, despite beta blockers, despite SGLT2 antagonists, despite mineralocorticoid receptor antagonists. So if you have given the treatment and still the EF ejection fraction is less than 35% for more than 45 days, your patient needs an ICD. This is one of the indications for ICD in a patient post-MI. Third indication is a witnessed syncope, or a witnessed syncope that could be attributable to a ventricular arrhythmia or a witnessed ventricular tachycardia. That is an absolute indication backed by class 1A evidence. Okay? So tell me, what are the indications for ICD implantation in patient post-MI?
So if ejection fraction is less than 35%, even after 45 days.
Great. What else?
Others is witness ventricular tachycardia.
Great. Or a syncope attributable to it.
Okay.
Within first year. That is also there. Okay. Now, the next presentation topic is stroke with a murmur. So now stroke is a neurological topic, but stroke with a murmur comes in the exam so often. These are two combined topics presented. So we need to remember that why stroke happens in a patient with murmur. The number one reason is embolus. So we call it a cardioembolic stroke. We call it a cardioembolic stroke. Now, why cardioembolic stroke? It is either a vegetation which gets plucked off from the valve. So it is septic emboli which goes to the brain, or it is an atrial myxoma which travels directly like a tumor emboli. Then it is prosthetic valve thrombosis. Patients who have prosthetic valves, they can get stuck valve or valve vegetation, pannus formation. So they can lead to embolic stroke in patients. Okay. Now coming to non-embolic causes. So it could be rheumatic heart disease, where itself, why does rheumatic heart disease lead to stroke?
Because rheumatic heart disease, so
Because of atrial fibrillation.
atrial fibrillation.
So in atrial fibrillation, we know that we do Chadwick score to calculate if the patient has a high risk chance for cardiovascular embolization. Okay. So rheumatic heart disease will lead to AFib. AFib will lead to formation of a thrombus in the left atrial appendage, and these patients can have recurrent embolism. Okay. Then, of course, non-embolic causes are presence of PFO. So PFO leads to a DVT, paradoxical embolism. So why paradoxical? There is a DVT in the leg of the patient. The clot goes from here. So now it goes to the heart via the venous system, and we understand that from venous system the clot can only go to pulmonary embolism. But if there is a PFA, there is a patent foramen ovale, the thrombus can move from RA to LA, and then from LA to LV, and then from there to aorta, and then it can go anywhere leading to a stroke. So murmur can be present in these patients because of number one, endocarditis. We know any patient with fever and murmur, new onset murmur is endocarditis. Atrial myxoma will also give you a murmur and chances of embolism. Prosthetic valve, of course, and then rheumatic heart disease and congenital heart disease. Okay. How do you assess these patients? Number one, clinical features to assess, or you can say the pointers in the question which can guide you to the answer are: number one, stroke or stroke-like symptoms like sudden onset neurological deficits, hemiparesis, aphasia, visual field loss, or signs of endocarditis like fever, splinter hemorrhages, ossular node, genital lesions. You need to remember your Jones criteria and modified Duke's criteria. Then cardiac findings: presence of murmur, newer or pre-existing. Then arrhythmias or prosthetic valve dysfunction. Then, of course, coming to imaging. So what we need is brain MRI, CT to confirm stroke. Along with, we need to do an echocardiogram, preferably transesophageal, because you can see atrial appendage very nicely in TE to identify vegetations like thrombi and atrial myxoma. So you need to get done MRI or CT immediately. Then you need to do an echocardiography plus a carotid Doppler, because from the atherosclerotic patches in the carotid, the atherosclerotic patch can the plaque, it can rupture and go to the brain, causing a stroke. Of course, ECG and Holter. Sometimes the patients have sinus rhythm when they come after stroke, but they have a murmur. So you need to detect any atrial fibrillation via 24-hour Holter monitoring. And blood cultures are also essential if there is a history of fever with a murmur to rule out infective endocarditis. Remember, having a blood culture positive is a major criteria for endocarditis. Bubble contrast disease study is done in which condition? Anyone?
Patent foramen ovale.
Yes. So we want to make sure that there is no gap in the interatrial septum. So we give a agitated normal saline. Agitated normal saline will have bubbles, and you can see in the echocardiography shiny bubbles traveling from right atrium into the left atrium, indicating patent foramen ovale. Okay. So management will be like any stroke. So acute stroke protocol, thrombolysis if eligible. What does eligible mean? What is the time to thrombolysis in stroke?
45 minutes. No, 4.5 hours.
So it is 4.5 hours. Earlier it used to be 3 hours. Now it is 4.5 hours. Maybe in an year or so it will become 6 hours, but as of now it is not 6 hours, it is 4.5 hours. So you can thrombolize if eligible. Thrombectomy for a large vessel occlusion. Thrombectomy is mechanical thrombectomy, which is done from 6 hours to 24 hours after the window of thrombolysis. Then, of course, addressing the underlying cause, antibiotics for endocarditis, anticoagulation for AFib, and surgery for atrial myxoma. Okay. So, are you ready for the questions?
Yes.
So, stroke and murmur. A 35-year-old man presents with sudden right-sided weakness and slurred speech. He's just 35. He has fever, weight loss, and new systolic murmur. Brain CT shows an ischemic stroke. What is the next best investigation?
Transesophageal echocardiogram.
So to rule out infective endocarditis. So combination of stroke, fever, and a murmur suggests infective endocarditis with embolism. So T is the most effective and most sensitive test to detect vegetations on mitral valve. Okay. A 45-year-old woman presents with recurrent transient ischemic attacks. She has no significant valvular risk factors but a mid-diastolic murmur. So she has mid-diastolic murmur and recurrent TIAs. This murmur is heard at the apex. What is the most likely cause?
Atrial
myxoma.
So can she have mitral valve prolapse?
No.
MR pansystolic murmur.
So number one, mitral valve prolapse will have a
pansystolic murmur. This is mid-diastolic murmur.
Yeah. So it will have a systolic murmur. Systolic murmur with a click. You know, it opens up and reaches a point and then there is a click because it cannot go further on and the papillary muscles, they pull it back. So it parachutes into the LA. Okay, rheumatic mitral stenosis with atrial fibrillation. Again, it will not be a mid-diastolic murmur. It will be a diastolic rumble and the patient will have history of palpitations. Okay, patent foramen ovale. So in patent foramen ovale, usually you cannot auscultate or any murmur. It usually is not there unless there is a Eisenmenger pathology, which is pushing the blood from right atrium to left ventricle, and there is a pulmonary hypertension murmur, which is auscultable on the left second intercostal space, just next to the sternum, and so that is present if the pulmonary hypertension is there. So answer is atrial myxoma. Atrial myxoma can present with embolic phenomena and a tumor plop sounding resembling a diastolic murmur. Recurrent TIAs without risk factor strengthens the diagnosis. Okay. A 62-year-old man with a history of aortic valve replacement develops sudden left hemiparesis. He is on warfarin with an INR of only 1.8. So he's being underdosed.
Yes.
A new systolic murmur is heard. What is the most likely diagnosis? So he's come with a stroke and with a history of aortic valve repair or replacement on anticoagulation, but a failed anticoagulation or inadequate anticoagulation. So prosthetic valve thrombosis. So subtherapeutic INR in a patient with mechanical valve, it increases the risk of thrombus or a PAMS formation. Stuck valve also is a known complication. Murmur and ischemic stroke suggest an embolic event from the prosthetic valve. See, these questions you never get prepared for because we either study stroke or we study, one of the reasons for stroke as. So this is very important. A 30-year-old man with IV drug abuse history presents with a fever, a pansystolic murmur, a sudden loss of vision in the right eye. What is the most likely diagnosis?
Septic embolism to the tumor. Infective endocarditis.
Okay, this
IV
is
drug.
septic embolism, fine. In case of IV drug abuse, where do you find the vegetation usually?
Right side.
So you will find it on the tricuspid valve
Yes.
usually,
Right.
but that is not essential. That but tricuspid valve vegetations are usually seen in infective endocarditis, seen in IV drug abusers. Okay. Summary points: always link stroke with systemic findings like fever, embolic phenomena. Always. So in MRCP level examination, stroke directly they will not ask you. They will either ask you TIA management or they will ask you stroke with murmurs. So that means directly it is either heart valves, prosthetic valves. So that is it. And of course, ECG changes, atrial fibrillation. Perform TEE in all patients with suspected embolic stroke and a murmur. Consider anticoagulation and source control as definitive measures. Okay, so now another topic: hypotension following acute myocardial infarction. Very important, very important. So nowadays, those students who are also preparing for EDIC, this is leading topic: EDIC, MRCP, USMLE, because this is actually having an insight into what will happen after the myocardial infarction. So key points to understand are that not all MI patients have heart failure. I mean, pump failure. They may have anything else. So pump failure is one of the differentials, which is called cardiogenic shock when there is pump failure. So it could be because of extensive loss of muscle wall, like in LV infarction, or failure of the blood supply to the left ventricle, that is RV infarction. So when right ventricular infarction is there, it will not be pumping enough blood to the left ventricle, so the patient will be in shock. Or there is a mechanical complication like papillary muscle rupture leading to acute mitral regurgitation, or there is a ventricular rupture, ventricular septal rupture leading to VSR, leading to left to right shunt and cardiogenic shock, and of course a free wall rupture leading to tamponade and sudden death. Then of course other causes for this thing, the shock, are having arrhythmias. Just a second. Bradyarrhythmias or tachyarrhythmias like complete heart block and sinus bradycardia, ventricular tachycardia, ventricular fibrillation. Hypovolemia, excess use of diuretics. We have squeezed the patient so much that there is hardly any fluid inside. Excessive use of diuretics and nitrates. Can you tell me nitrates are contraindicated in which kind of myocardial infarction?
Inferior wall abuse.
Yeah, or right ventricular MI. Okay,
Yes.
RVMI, inferior wall is still left ventricle. So, but when we specifically say RVMI, it is very clear that we do not want to give this thing.
Right.
Okay, yeah. So, bleeding from anticoagulation, if the patient has bled, hypovolemia will happen. Drug effects, overuse of vasodilators, for example, nitrates. Clinical clues. So, if in the history you find that patient has clear lungs, elevated JVP, hypotension which is worsened by nitrates, you should immediately jump to the conclusion that patient has a right ventricular MI. This will fasten your response time. Clear lungs, there is no fluid in the lungs do not have pulmonary edema, but the patient is in shock. JVP is elevated, but lungs are clear. This is a worst combination for a patient. So this means that the patient has a RVMI. Then tamponade mein patient will have muffled heart sounds, pulsus paradoxus with elevated JVP. What is pulsus paradoxus? What is pulsus paradoxus? इतना डिफिकल्ट क्वेश्चन तो नहीं है.
No.
A condition where there is a larger than normal drop in systolic blood pressure.
So basically, systolic blood pressure decline is usually around 10 centimeters, but it declines much more than 10 millimeter mercury during inspiration. So when we inspire the BP, the systolic blood pressure
Fall more than 10 mm.
False.
Yeah, falls. So if it falls
Just
more than
opposite
10
is
mm,
pulsus
so it is an exaggerated response. Okay, it is an exaggerated drop in blood pressure. So that happens in tamponade. Okay, septal rupture. What are the clues? Immediately the patient will be fine. History will be that the patient was taken up for primary PCI who came with STEMI anterior wall. We did a primary PCI. The patient was shifted to the cardiac care unit, and immediately after 40 minutes, the patient developed pulmonary edema, breathing difficulty, required NIV, and settled with diuretics, but has a pansystolic murmur at the apex or at the mitral area. So that is septal rupture because of infarction of the papillary muscle. There is hemodynamic instability, and the patients, they really don't do well unless you take them up for emergency bypass grafting and suturing of the papillary muscle. Acute mitral regurgitation is again a similar condition like septal, not the septal rupture, but papillary rupture. So both of them, they are almost similar. And immediately you need to put a intra-aortic balloon pump so as to decrease the SVR so that blood follows the trail of low BP. So it will go into the aorta. So what will happen is do you understand this?
Yes.
So I'll draw it for those who don't. So this is the heart, and I'll draw both the conditions here. So this is mitral valve rupture, and this is VSR. So what is happening is this is connected here, but this is now frail because this is ruptured, and this papillary muscle is literally dancing freely here. I'll draw again. So this is freely, but then this valve is there. So this valve goes up during systolic motion, and there is mitral regurgitation. And this is a ventricular septal defect through which blood goes into the RV from left ventricle. And these are both common complications, usually third to fourth day, not so early. But then we need to know that in examination, they can just move the day 1 or 2 ahead, once or forwards. But then these are the two major mechanical complications that come after myocardial infarction, anterior wall specifically, and can present with cardiogenic shock, which is refractory. So investigation, bedside, we need to do an ECG to identify RV infarction and arrhythmias, echocardiogram to look for any mechanical complications like a VSR or a ruptured papillary muscle. Bloods, troponins, lactate, arterial blood gases, they are important. Lactates are important. We'll just look into the shock algorithm. Chest X-ray to see pulmonary edema, curly B lines, cardiomegaly, and all these things. Management of cardiogenic shock is inotrope, for example, dobutamine. It is specifically known as an inodilator. Why? Because it dilates the systemic vascular system, leading to decreased systemic vascular resistance and allowing the more blood to flow into aorta. Okay, intra-aortic balloon pump along with vasopressors. RV infarction, all we need to do is volume expansion, avoid nitrates and diuretics. Tamponade, emergency pericardiocentesis. Mechanical complications require urgent surgical intervention. These are the major 4 pillars of management of post-myocardial infarction shock. Is that clear until now?
Yes.
Great.
Yes, sir.
So this is the definition of cardiogenic shock, where systolic blood pressure is 60 to 90 or a mean arterial pressure drops below 65 millimeters of mercury and a lactate of more than 2.5. So this is why importance of blood tests in lactate. So lactate, elevated lactates define this condition of, or an ALT more than 200 to 500, that is acute liver injury. So this is called shock liver. No drugs, no device. So, and we understand that the patient will die if you do not give anything. Okay. So in multimodal evaluation, you need to get an echocardiography done. You need a pulmonary artery catheter, although not being followed much these days, or at least a central venous line, an ABG to see the lactates, and of course, arterial BP monitoring with PAWP, that is pulmonary artery wedge pressure plus cardiac output monitoring. Okay. Now the problem can be at four fronts. Number one, it can be at a front of contractility, like loss of major muscle, loss of major muscle. So EF has declined. When the EF has declined, it will lead to a decreased cardiac output, decreased cardiac index, decreased and increased SpO2. What will help? Dobutamine will help, levosimendan will help, PD3 inhibitors, they will help. For example, what are the PD3 inhibitors? Anyone?
This phosphatized
Sorry.
in a milrinone.
So milrinone. Then if the preload is the problem, of course, you will like to, if it is decreased, you will like to give crystalloids to increase the preload, for example, in RVMI. And if it is already increased, you will like to dialyze or diurese to decrease the preload. So you will have to define in which direction you are going. If it is a high preload heart failure, then you will decrease the preload. If it is a low preload heart failure, then you will increase the preload. Coming to afterload, if the blood pressure, mean pressure is less than 65, or the mean pressure is less than 120 systolic BP, then you would add a norepinephrine or vasopressin. If it is more than 70 mean arterial pressure and more than 120 systolic blood pressure, then be brave. Add intravenous nitrates. Dilate the system. Decrease preload, decrease afterload. The patient will start getting better. In patients who have heart rate issues, less than 60 or more than 110, if it is less than 60, you can add isoprenaline, or you can do a pacing if there is a sinus arrest or AV nodal blockage or complete heart block. Or if the heart rate is more, then you can add, either do cardioversion if it is a ventricular bigeminy tachycardia. Normally bigeminy we do not treat, but if it is a heart failure patient, pulmonary edema, then we would like to get the patient back into a sinus rhythm. So beta blockers also. General rules derived from acute myocardial infarction is number one, open up the damn vessel. Whichever vessel is a culprit artery, open it up. Add inotropic drugs to target effective cardiac output. If still not successful, add vasopressors to vasoconstrict the patient to target effective mean arterial pressure. Then still not, then LV unloading, add an IABP for mechanical complications. Or which are the newer agents, newer devices for IABP? LVAD and Impella. Okay. Along with that, there are certain other conditions which can happen in patients with coexisting acute myocardial infarction. Is number one, Takotsubo syndrome, where you have a classical flask-shaped LV. So immediately you will stop all sympathomimetic drugs like norepinephrine, epinephrine. Consider non-adrenergic inotropic drug. Which is a non-adrenergic inotropic drug? Anyone?
Phenylephrine.
No.
Milrinone.
It is either milrinone or levosimendan. Levosimendan is a calcium channel antagonist. Identify the cause of LVOT obstruction and beta blockers. Basically, Takotsubo occurs because of an excessive sympathetic drive, which causes spasm of the proximal part of the heart, and rest of it dilates. So it's a flask-shaped heart, usually seen in, it is also known as heartbreak syndrome. When somebody has a sudden shock, adrenergic surge leads to spasm of the LVOT. Same is with the condition in hypertrophic cardiomyopathy. Again, you don't need any inotropic drugs. You don't need any NTG. So you immediately stop them, identify the obstruction, give beta blockers in good dose, and give good amount of IV fluids as well. Is this chart clear to you?
Yes, sir.
Great. So these are the newer devices, and of course, this is more for EDIC students, but I just wanted to make a passing reference here. So we have three devices. Number one, IABP, number two, Impella, and number three is VA. How does IABP work? It works by the concept of counter pulsation. Counter pulsation means when heart is in systole, the balloon is in diastole. And when heart is in diastole, the balloon is in systole. Is that okay? So that is counter pulsation. So how much support does it add? It adds around half a liter of cardiac output to the patient. And then, do you want me to go into the details?
Yes, sir.
Okay, fine. So in IABP, it is basically counter current pulsation. Counter pulsation. That's a mosquito. Okay, this is a helium-filled balloon, and we leave it in the fourth intercostal in the thoracic aorta, somewhere here. So what it does is, when the heart is contracting, let me draw it somewhere. When the heart is contracting and trying to push blood into aorta, it is in an inflated state, which is called a diastolic state of balloon. So it is inflated. Imagine the heart has pumped the blood. Earlier, it had to pump the blood to whole of the body. Now it just has to pump up to this level. So heart becomes more efficient. It just has to pump it here. Now, when the blood reaches here and cannot go any further, aorta distends. When aorta distends, it accommodates all the stroke volume that heart has pumped into it. Then when the heart goes into relaxation mode, suddenly the balloon shuts close. And what happens? When the balloon shuts close, then there is a runoff of the blood immediately by the aorta. Aorta contracts and the blood pumps into the peripheries. So this is the concept of counter pulsation. And moreover, when the balloon is inflated and heart is pumping the blood into aorta, what happens is coronary perfusion happens, because now this blood goes into coronary perfusion.
Yes, sir.
Yeah. So this is the benefit of IABP. Okay. Then comes Impella. Okay, Impella is not asked in MRCP exam, but then it is a device. It is a device which is put into the heart from here. So it is basically is lying here in just close to aorta, and it's like a motor here. And it will pump the blood into aorta, and you can have a complete cardiac output of 2.5 to 3.5 liters. Okay, so that is Impella. Then, okay, another thing, Impella causes something which is called a pulseless circulation. Why? Because it is a rotator. It is just rotating. It is not pulsating. Okay, so it is just pushing the blood into the circulation with the every contraction. LV is contracting on its own, but this is pumping the blood. All right. Then comes ECMO. ECMO is VA ECMO. What are the indications? When everything else fails, VA ECMO. You can generate up to 7 liters of cardiac output with VA ECMO. Very effective. It removes, not only provides cardiac output, but also removes carbon dioxide and provides oxygenation with the help of a transmembrane oxygenator. Now, these are the little things that you need to be prepared for. Sometimes they can ask you some questions. So, but you have to define that where do you need these mechanical devices. Where cardiogenic shock is refractory to inotropes, it is defined as refractory cardiogenic shock. So it is an entirely different class of disease, because it is not presenting in OPD. So MRCP guys will only ask you a in-passing reference. All right. So a 60-year-old man presents with hypotension, elevated JVP, clear lung fields, and recent diagnosis of inferior STEMI. Where is the most likely infarction? Right ventricular. Very good. Okay. A 68-year-old woman develops hypotension 3 days after a large anterior STEMI. She has a new harsh pansystolic murmur, signs of pulmonary edema. What is the most likely cause?
Septal rupture, free wall.
Ventricular septal rupture. Very good. Why not papillary muscle rupture?
That will
Pansystolic murmur is not.
Okay, pansystolic murmur can be there in that murmur also. So
anterior wall MI most commonly will lead to.
yes. So what will happen is posterior wall, like lateral walls, lateral circumflex, these will lead to papillary muscle rupture. Okay. A 70-year-old man presents with hypotension and narrow BP for 2 days after large MI. His tachycardiac, muffled heart sounds, elevated JVP, and paradoxical pulses paradoxus. What is the likely diagnosis?
Tamponade.
How will you treat?
Pericardiocentesis.
Wonderful. So you immediately go for?
Immediately.
Yes. And what is the diagnosis?
Tamponade.
Tamponade.
Give me complete diagnosis.
Cardiac
Tamponade is
tamponade.
not a diagnosis.
Rupture,
Single.
free wall rupture post.
Yes. So it is cardiac tamponade secondary to free wall rupture.
Yes.
Because cardiac tamponade to pleural effusion, Dressler syndrome se bhi ho jayega. We have to define cardiac tamponade secondary to Dressler's, secondary to acute free wall rupture. So this is how it is defined. So diagnosis, we try to encompass primary and secondary diagnosis both.
Second,
so primary
restless.
diagnosis is, yes.
Second, can restless present with tamponade, sir? It's a long standing after 2 weeks.
Very good question. But I have seen at least 3 patients who came with a massive pericardial effusion amounting to tamponade. Basically, what happens is our own fault. We diurize the patient so much because patients ask on telephones. So they call up, saans chad raha hai. So post-MI patient, you never think of Dresslers immediately. You think of heart failure. You tell them to come, but they need some medication. You tell them, okay, take a Ditor. So what happens is they continue taking diuretics, and the tamponade happens because of the differential between the right ventricle and the this cardiac tamponade. Most of the time it's moderate, but then patients deteriorate because they are continuing to take diuretics and not presenting for a follow-up. Is that clear?
Yes.
Okay, sir.
Yeah, because it is the gradient in cardiac tamponade. It is not the left ventricle which ever gets compressed. It is the right ventricle because there is no muscle at all. You getting me?
Yes.
So what
Yes,
happens is the more diuretics you give in, that is why you don't give diuretics in a patient who has pericardial effusion. Because the effusion is being kept at the level of effusion because of the good RV filling. Imagine if you've taken the preload out, the RV will be compressed by the whatever fluid is there. Are you getting my point?
Yes.
So that is why diuretics, and you should also never give anticoagulants to a patient who has pericardial effusion. Okay, because it can actually develop into a normal pleural pericardial effusion into a hemorrhagic pericardial effusion. Then it is very difficult. Okay, 65-year-old woman develops severe dyspnea and hypotension 2 days after a posterior STEMI. She has a new systolic murmur at the apex, and echo shows severe MR. What is the most likely cause?
Papillary muscle.
Easy, very easy. Okay. A 58-year-old man with recent anterior wall STEMI develops hypotension and confusion. ECG shows sinus tachy. Bedside echo shows severely reduced ejection fraction. What is the most appropriate management? Will you give IV fluids to this patient?
No, sir.
Will you give will you give dobutamine?
No.
No, why?
No, yes.
Because the first drug is an inotrope, right? So you will give an inodilator, a dobutamine. Before it becomes a refractory cardiogenic shock, you have to go through these stages of giving IV dobutamine. And in case it causes the blood pressure to fall, you will add a vasopressor.
Yes, sir. First we have to add the vasopressor. Then we'll give dobutamine, sir.
No,
After increasing the blood pressure.
depends. See, there is hypotension. Yeah, you can, because there is hypotension, and hypotension is defined as BP less than 80 systolic. So, but the point is, by the guidelines, you should add a dobutamine first. Although in practical purpose, we add both of them together. Mrcp and dobutamine together. So we would start the patient on IV dobutamine infusion to increase the cardiac output. Summary points are: hypotension post-MI often indicates life-threatening complication. Bedside echo is critical to differentiate between mechanical and functional causes. We need to tailor the management to the underlying cause. Okay. So next we will do in the next class. Okay. So we will take 1 hour class because cardiology is a beautiful topic. We just cannot brush through the topics and be relieved. So we can take a 1 hour class, whichever day you decide. You can let Fatima know. I mean, at First Academy, I have a lot of material to give you, but the thing is, I will take a lot of time. So this is ACS, and then we will cover more arrhythmias also, and every topic. So we will need more time. Cardiology is something which has to be covered in a very comprehensive manner. So, all right, doctors, we will do
Yes,
the rest of the topic, and we will do 1 hour class, maybe 1.5 hours, but only this much because it is a very intense topic. I also have to speak. Then we'll do 1 hour. Is that okay?
yes, sir.
Okay.
We'll cover it in 4-5 classes.
Okay, sir.
All right.
Okay.
Okay. Good night. Bye bye.
Good.
We
Yes.
really had a very good class. We'll meet soon. Thank you, Dr. Varun Pushkarna.
Thank you.
Thank you,
you.
sir.
Okay. Bye. Good night.